Hello, this is an educational module on temporary pacemakers. My name is Catherine Miller, and I'm a clinical nurse specialist with a background in critical care and a love for all things cardiac. Temporary pacemakers is frequently requested as a topic for education and skills refresher, so I'm happy that you found this module and hope that you find it helpful. This is intended to provide an introduction to temporary pacemakers, whether you're a new RN or pacemakers are new to you. This may also be beneficial to experienced nurses who see pacemakers infrequently and would like a refresher. We'll go over concepts of pacing, the concepts of nursing assessment, and a simplified approach to troubleshooting common pacemaker issues. Here are just a few of the indications for temporary pacemaking. A patient presents to the emergency department and we identify a complete heart block or another bradyarrhythmia. Maybe they mistakenly took an extra dose of their beta blocker. There might be an electrolyte imbalance, and often the reason is unknown. Perhaps they already have a permanent pacemaker that's acting up, and temporary pacemakers are also used as part of the post-op recovery pathway for open heart surgery. There are three types of temporary pacemaking available. The first, transcutaneous pacing, is an emergency, extremely temporary option for pacing that uses external pads and a defibrillator with the settings and capabilities to pace. I mentioned transcutaneous pacing as a type of temporary pacing, but it won't be the focus of this module. The second is transvenous pacing, which uses pacer wires that go through a large bore sheath into the heart. The venous sheath is typically in the femoral vein or the internal jugular. Once inside the heart, it anchors into the wall of the ventricle. The part of the pacer wire that remains outside of the body is connected to a pacemaker generator box. A sample of this box is shown there on the right. Epicardial pacing wires are sutured out to the outside of the heart. You can see an example here, the atrial wires and the ventricle wires. Pacing wires have to be placed when the heart is exposed, such as during open heart surgery. Wires are sutured to the heart and threaded outside of the body, typically below the incision. And epicardial wires use the exact same pacemaker box as the transvenous setup. When thinking about temporary pacemakers and how they interact with the heart, there's two pathways to consider. The first, the heart sends a message about its own native ECG activity to the pacemaker. How often is it beating, and the voltage of the electrical activity. Depending on this message that the heart is sending, the pacemaker can both monitor and deliver electrical activity. Monitoring and responding to the heart's rhythm is going to be based on the pacemaker settings, which we'll talk about on the next slide. For a pacemaker to respond to the heart, it needs to be programmed with a few settings. The first being a set rate. When the heart rate drops below this set beats per minute rate, the pacer will initiate an electrical impulse. Output, measured in milliamps, is the amount of electricity needed from the pacemaker to stimulate the myocardium of the heart. Sensitivity is measured in millivolts. This is the voltage level set for the pacemaker to be able to see the heart's own electrical activity. The principles of pacing are very dependent on where the wires are. So for example, to sense and provide electrical impulse to the ventricles, a patient needs ventricular wires. When the pacer delivers electrical stimulation to the heart, it creates a paced beat. Remember back to the examples of temporary pacemaking. For epicardial pacing, the wire is sutured to the outside of the atrium or the ventricle. In transvenous pacing, the wire is up against the internal wall of the ventricle. For ventricle paced beats, the electrical activity starts in the ventricle and travels out, very different from the SA node to the AV node through the bundle of His. This creates a very wide, ugly QRS compared to the normal QRS following the natural conduction pathway. For atrial pacing, the beat looks a little more normal for a few reasons. The wire is sutured much closer to the SA node, where the conduction system naturally starts. Once the atrial muscle is stimulated, the electrical pathway will then follow the normal AV node to bundle of His, creating a very normal-looking QRS when A pacing. To better understand sensitivity, let's compare sensitivity to a radio. The volume of a car radio determines how well you can hear the passengers riding with you. If my radio is really loud, I'm not very sensitive to the conversation, tuning it out. If the sensitivity is set too high, the pacemaker isn't very sensitive to the heart's native rhythm. It perceives that the pacemaker doesn't really care what the heart is saying. In the opposite scenario, if my radio volume is extremely low, I may hear a few things that I don't want to hear. A little rattling under the hood, maybe someone's tummy is growling. The point is, a little bit of radio is a good thing. So a pacemaker with a sensitivity value that is set too low means that the pacemaker can hear all of those extra noises that creates confusion, particularly if the purpose of the pacer is to pace the ventricles and it hears the extra noise of the atria, this is going to cause some confusion in those settings. If the radio example isn't for you, there's also a fence analogy. In this case, the height of the fence is equivalent to the sensitivity that is set on the pacemaker. The pacemaker can only see what's over the fence. For this analogy, let's assume that we're talking about ventricular pacing. The pacemaker's sensitivity is set to see what the ventricles are doing, so it's looking for QRS complexes, as seen in this image here. Continuing with the fence analogy, if the sensitivity is set too high, the pacemaker doesn't see any of the electrical activity, which makes it think that it needs to start pacing. This will create asynchronous pacing and be an issue that we'll talk about later. If the sensitivity is set too low, the fence is too low, the pacer sees too much electrical activity. So in this scenario, despite there being no perfusing beats, the pacemaker is going to assume it sees electrical activity, everything must be fine, and won't deliver any output. Okay, let's recap the pacemaker terminology, applying it to the pathways that we discussed earlier. So the heart sends the pacemaker its native rate, as well as the millivolts, which is the sensitivity setting of the ECG tracing. And the pacemaker can sense that rate and millivolts of the heart's ECG and respond accordingly. There's two options in how the pacemaker responds. If the pacemaker senses a rate or millivolts that's below the programmed settings, it will deliver electrical activity to produce a paced beat. The amount of electricity is measured in milliamps, which is our output setting. If the pacemaker senses a rate or millivolts of the ECG activity that is adequate or above the program setting, it will stand down and continue to sense without pacing. The features of this sensing and responding gives us the pacer mode, which we'll discuss on the next slide. Pacer modes are made up of 3 letters. The first letter is the chamber of the heart that can be paced. If there are wires sutured into the atria, we have the capability to pace the atria, also known as A pacing. If there's ventricular wires, V pacing. If both atrial and ventricle wires are present, then the first letter is D for dual chamber pacing capabilities. The second letter is the chamber being sensed. So remember that heart pacer pathways that we talked about earlier. The wires being used to pace are the same wires responsible for bringing the sensed information from the heart to the pacer. So there's really no mixing and matching here. You won't ever have a VA or an AV as the first 2 letters. A wire placed to pace the atria is not set up to sense activity from the ventricle. The third letter is the sense response. This is the pacemaker's response to the heart. Now remember I said earlier, if the pacer senses that the heart's rhythm is adequate based on the program settings, it will stand down. This is called inhibiting. The pacemaker will inhibit itself from pacing. If the third letter is D, it means that there is sensing capabilities for both chambers of the heart, and may pace one chamber and inhibit the other, just depending on the sensed need. You'll see under the commonly used modes, I've also listed emergency pacer mode DOO. Not because this is a common mode, but it's a good time to introduce this. The D means dual chamber pacing. The O's stand for none, so there's no sensing and no sense response. Resorting to this mode implies that there's a non-perfusing ECG rhythm or no rhythm at all to sense or respond to, and that we need the pacemaker to blindly pace at a maxed output. Routine assessments and documentation of the pacemaker should occur as part of the patient's head-to-toe assessment. It's important to peek at the skin around the wire insertion site and check all the points of the connections from the pacemaker to the patient. The wires going to the cables as well as the cables plugging into the pacer generator box. Verify the orders and be familiar with the settings in the pacer box. Ensure that they match. In this example, we've charted that our mode is VVI, capability to pace and sense the ventricles, and the pacer will inhibit itself unless the heart rate goes below the program settings, which in this case, a rate of 50 beats per minute, an output of 10 milliamps, and a sensitivity of 2 millivolts. These documentation groups are found under the Adult Assessment Doc flowsheet. Now that we've covered some of the basic pacer concepts, we'll take the next few slides to talk about troubleshooting pacemaker problems and simplify this into 3 main categories. The first category is failure to capture, which is an output problem. You see pacer spikes without a corresponding ECG complex. In these sample tele strips, can you see the pacer spikes that don't follow with a QRS? In these examples, the heart is inconsistently responding to the pacer's delivered milliamps. In general, this means there's an insufficient energy somewhere in the pathway from the pacer to the heart. This may be a result of low batteries. It's possible that the wires or the cables are loose or have become dislodged, interrupting the electrical delivery to the heart. And there are some clinical reasons that the heart may be less receptive to the current level of milliamps being delivered. Acidosis, hypoxemia, and electrolyte imbalances can create a failure to capture. After a quick battery check and connection check, you'll want to increase the milliamps, the output setting on your pacer box, until you see 100% capture, an EKG spike for every pacer spike. Next, we have failure to sense. This is a sensitivity problem. If this is your problem, you'll see pacer spikes all over the place, almost as if they're competing with a patient's own rhythm. Think of this as a glitch in the heart to pacer pathway. The heart's own rate and rhythm is there, but the pacer is inappropriately sensing. It's possible that the physical connections are dislodged or loose, creating that glitch. And there may be some subtle clinical changes in the heart where there's a lower myocardial voltage causing problems with the current sensitivity settings. But often the pacemaker is insensitive to the patient's intrinsic rhythm. The pacer can't see or hear, depending on whether you like the fence or radio analogy more, what the heart is actually doing. Your response to this problem is to lower the millivolts in the sensitivity setting. This will make the pacemaker more sensitive to the heart's own rhythm. The biggest concern with pacer spikes being inappropriately competing with the patient's own rhythm is that the pacer might deliver a shock on the T wave. This is called an R on T. Zapping the ventricles when those cells are trying to relax can send the heart into VFib. Will this happen every time there's a failure to sense? No, but it is important and does require your immediate attention to avoid this lethal rhythm. The last category is failure to fire. This is a combination problem with both output and sensing issues. As you can see in the examples, the heart pauses, so there's no ECG complexes. The pacemaker doesn't sense it needs to pace and therefore doesn't deliver any output, so there's no pacer spikes. Your immediate response will really depend on the length of the pause and how symptomatic the patient is. If that pause turns out to be asystole, then absolutely call a medical emergency. It may not be instinctual, but as you're activating the medical emergency teams, also attempt the emergency pacer settings. This is the red button at the top of the pacer that says DOO. This is the emergency pacing mode. This will maximize the output delivered to the heart, giving you the best chance of regaining capture. If you're not quite to that medical emergency, but you're noticing intermittent failure to fire issues, I'd recommend placing transcutaneous patches on the patient and be ready to transcutaneously pace while you are troubleshooting the pacer issues. So to wrap up, there's a few general things you can do when facing a potential pacemaker problem. First, stay calm and quickly assess your situation. If your patient's unstable, prioritize activating any emergency response teams or resources. Once you've called for additional help, or if your patient's stable, continue your investigation. Check all of the external connections between the wires and cables. It's common. Problems will arise when there's incomplete pathways between the heart and the pacer. If this is in fact the problem, correcting those loose connections will resolve the issue. While not as common, if you happen to see extra spikes on the monitor, this can create an appearance of a problem, but may only be artifact or electrical interference not associated with the pacemaker, but showing up on the monitor. Validate that the pacer spikes you see on the monitor or telebox are truly pacer spikes from the pacemaker. There's a blue and green light on the top of the pacer box. These are labeled and will flash if the pacemaker is either sensing or pacing. Hold the pacemaker next to your bedside monitor or telebox. The sensing light will flash with every heartbeat, and the pacer light will flash when it's in fact delivering electrical activity. Does this match up? If it does, can you then identify if this is an issue of sensitivity, output, or both? Remember our 3 categories of pacemaker problems. What do you see? Maybe say it out loud. Are there spikes and EKG competing? Are there spikes but no EKGs? In attempting to adjust these settings to resolve the issue, if that doesn't work, return to the ordered settings and take your next steps. At this point, you might want to bring in your backup equipment, a transcutaneous pacer, just in case pacing fails, and, if available, swap out your pacemaker generator and/or exchange the cables. Assuming you can resolve the pacer issues with either exchanging equipment or adjusting settings, you'll eventually need to notify the provider of what occurred. You may also need to call the provider sooner for support in advanced troubleshooting if these initial approaches don't work. And that concludes this pacemaker overview. Hopefully this has been helpful. I really encourage you to mentally practice your response to potential pacemaker problems, but keep it simple. Run through the 3 common pacer problems and what you do. Pacemakers are a great tool for patients that need them, and it's important for nurses to feel educated and confident. Thanks for listening.